Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Dear colleagues and dear PGs, we are discussing the updates on hepatitis E, and today is the fourth video of the series. Today we shall discuss the chronic hepatitis E and its progression into liver cirrhosis and its sequelae, as well as we'll discuss acute and chronic liver failure as well, and we will see who are the cases where the ACLF appears in such patients. Just to recap, we did discuss that every year 20 million cases of hepatitis E happens. Out of these 3.3 million, they are symptomatic, and 70,000 of these, they die. We did notice that the hepatitis E virion may be naked in stool, and it may be enveloped in the blood. Then we discussed that the genome of the hepatitis E virus has got three open reading frame 1, 2, and 3. And we also discussed that the hepatitis E virus belongs to Hep viridae family of the orthohep virus genera, the species A, and it has got the 8 genotypes. Genotype 1 to 4, they are clinically relevant. Then we discussed the clinical course of hepatitis E virus infection, that it may be having hepatic manifestations, extrahepatic manifestations, and hepatic manifestation depends upon whether the patient's liver is normal or a patient is having chronic liver disease. When the patient is a normal liver, then if the patient is immunocompetent or immunosuppressed, in immunocompetent, a patient may be asymptomatic or may develop acute hepatitis or even acute liver failure. While immunosuppressed patients, the asymptomatic and acute hepatitis varieties are the same as those of the immunocompetent, but the severity is a bit different and enzyme level is a bit different. One thing, in immunosuppressed patients, they can develop a chronic hepatitis and then the liver cirrhosis, and we shall be discussing these two modalities in today's video. And if the patient has got the chronic liver disease, then this is the group where the patients can develop ACLF. In the last video, we discussed the acute hepatitis patients in immunocompetent with normal liver, and then acute liver failure patients in immunocompetent individuals with normal liver. And we also discussed the acute hepatitis in immunosuppressed patients with the normal liver. Today, we shall discuss the chronic hepatitis in immunosuppressed patients with normal liver. So today's discussion will be, one is with the patient with the normal liver but immunosuppressed, and then the patients who have got chronic liver disease because of some other reasons, and if they develop acute hepatitis E, what happens in that condition. So the chronic hepatitis E, till couple of years, I mean, maybe just 10 years ago, it was considered that hepatitis E causes only acute hepatitis. It was in 1987-88 when the chronic hepatitis E cases were reported with genotype 3 and 4, and since then, no, it's the known reality that we can have the chronic hepatitis E just like chronic hepatitis B and chronic hepatitis C. The chronic HEV infection is defined as the detection of HEV RNA in serum or stool for longer than 6 months. This is the traditional definition of chronic hepatitis. The incubation period is longer than seen in immunocompetent hosts because this is the immunosuppressed hosts where the chronic hepatitis happens. So the incubation period is longer, and when you trace the history, it may not be 40 days or 45 days. It may be even in months, 3, 4, or even 6 months. A chronic HEV infection is almost exclusively secondary to hepatitis E virus genotype 3. This is one point. One case of hepatitis E virus genotype 4 infection has been published, but none due to hepatitis E virus genotype 1 or genotype 2. So this is the genotype 3, which causes chronic hepatitis E in immunosuppressed individuals with normal liver. Immunosuppressed patients may include those who have undergone transplantations. It may be liver transplants, it may be kidney transplants. So these are the patients who are immunosuppressed, who take the immunosuppressed drugs. And when they develop acute hepatitis E, and if this is genotype 3, then there's a chance that they can progress into chronic hepatitis E. If they are infected with genotype 1 or genotype 2, then the progression to chronic hepatitis E has not been reported. Second group of immunosuppressed patients include those who are HIV infected and have low CD4 T lymphocytes counts. This is another group which, if they are infected with acute hepatitis E and if it is genotype 3, the chances of chronic hepatitis are high. And the third group is those on chemotherapy, especially in hematology units, those with hematological malignancies who are on chemotherapy cycles. If they develop acute hepatitis C, and if this is genotype 3, then they can progress to chronic hepatitis E. Again, to remind, if they are infected with genotype 1 or genotype 2, they do not progress to chronic hepatitis E. In some patients with chronic hepatitis E, both the antibodies of IgG and IgM may be negative. So patients who develop chronic hepatitis E, but when you check their antibodies levels, both IgM and IgG may be negative. Therefore, the PCR should be done in such cases on serum, plasma, or stool samples. So you can do the PCR on the serum, on the plasma, on the stool to find out if this is chronic hepatitis E. 2/3 of solid organ recipients with HEV develop chronic hepatitis. So if 100 patients with solid organ recipients, they develop acute hepatitis E, and if this is genotype 3, 2/3 of them, they will develop chronic hepatitis. The progression of cirrhosis is fairly rapid as compared to hepatitis B and hepatitis C. The progression to cirrhosis is fairly rapid in chronic hepatitis E. Around 10% of these patients develop cirrhosis within 5 years, and this is a very, very rapid course. And 1/3 of patients may achieve viral clearance, those who had developed this chronic hepatitis, and dose reduction of immunosuppressive therapy may be just sufficient in these patients. So if a patient has developed chronic hepatitis E, 1/3 of them, they will achieve viral clearance with dose reduction of the immunosuppressive therapy. In the rest, you will need ribavirin. And what's the dose of ribavirin? Ribavirin is given at a median dose of 600 milligram per day for 3 months. So it is a 600 milligram ribavirin per day for 3 months, and it gives results of the SVR of 78%, almost 80%. So it may be given in a single dose, 600 milligram, or it may be given in the split dose. But the 600 milligram per day for 3 months has given SVR reports of 78% in chronic hepatitis E patients. So the 1/3 of the patients, they may just clear their virus by simple reduction of the immunosuppressive therapy, while if they need ribavirin, it should be 600 milligram per day for 3 months, and it will give the SVR of 78%. Now, touching on the liver cirrhosis, immunosuppressed patients with chronic hepatitis E may rapidly progress to end-stage liver disease even within 1 month of their HEV infection. And I just in the last slide I mentioned that the within 10% of these they develop cirrhosis within 5 years. So this is a very, very rapid course. Between 46 and 80% of the solid organ transplant recipients, they cannot clear the virus spontaneously and under the risk of chronicity, and therefore they must be treated with ribavirin. There are some risk factors reported for the development of chronicity. Who are those patients who will develop the chronic hepatitis E in solid organ transplant recipients? And these are those who are using tacrolimus, are those who have got the low lymphocyte count at diagnosis, and those who are the patients with liver transplant. So if a patient with liver transplants, if a patient with low lymphocyte count, and if the patient who is using tacrolimus, if they develop acute hepatitis E, and if this is genotype 3, there are higher chances that they will develop the chronic hepatitis and then its sequelae. Now, the last topic of today's video's discussion is the ACLF, and when it develops it up, as the name says, the patient's liver should be already having chronic liver disease. So if they develop acute hepatitis E, irrespective of the genotype, they will develop acute and chronic liver failure. So the chronic liver disease, as I said before, it can be caused by several underlying diseases like chronic hepatitis B, chronic hepatitis Z, non-alcoholic steatohepatitis, alcoholic liver disease, autoimmune liver disease, or hereditary diseases like hemochromatosis or Wilson disease. Whatever may be the cause of the chronic liver disease, if these patients develop acute hepatitis E, and whatever genotype it may be, there's a chances that they may develop acute and chronic liver failure. The ACLF chances are higher in these patients. In a large study from India, it was a cohort of a big number of patients with chronic liver disease. The hepatic decompensation due to HEV infection was related to a worse outcome as compared to decompensation due to another cause, and the 12 months mortality was as high as 70%. So it's a big cohort, and when they compared the ACLF because of the acute hepatitis E and ACLF because of the other reasons, the patients of the ACLF patients because of HEV, the 12 months mortality was very, very high at touching the 70% as compared to the other causes where the mortality was not that high. So in the small studies from developed countries also report a poor prognosis in patients with underlying chronic liver disease. So I'll stop here, and in the next study, we will discuss this ACLF in more detail, and I'll share with you the different studies from the literature, as well as one study which is a more detailed one, details on that, to tell you that how the ACLF, because of the hepatitis E, makes a difference and what is the outcome of these very patients. So till then, it's Khudafis. Take care of yourselves. So see you in the next video. Thank you, Khudafis.